Good afternoon, everyone. On behalf of Fight Colorectal Cancer, I'd like to welcome you all to today's webinar, Lynch Syndrome and Hereditary Colorectal Cancer. So we are very excited to have all of you. We're going to go ahead and start with this afternoon's presentation. I'm Andy Dwyer. I work with the Colorado School of Public Health, University of Colorado Cancer Center, in a joint appointment with Fight Colorectal Cancer. So we're very excited to have everyone today as we get ready to come into our 1 million strong event. As you all know, or you've seen a lot of social media promotion, Fight Colorectal Cancer will be partnering with a number of academic and community organizations in Nashville for our annual 1 million strong event to celebrate the 1 million cancer survivors and their support community as we move into health or promotion of survivorship, education, and resources for those who are colorectal cancer survivors. So we're really excited to have everyone on today as we feature one of our key panelists, Heather Herrmann, who will be joining us to talk a bit about Lynch syndrome and cancer genetics. Next slide. Okay, so just as a reminder today that after Heather does present, the webinar will be archived for later viewing for all of those who are interested on the Fight CRC website. After the webinar, we will be sending you some evaluation and survey information to gather a bit of info about you, the interest in the topics that we're covering, as well as relevant information about Fight CRC and continuing to meet the needs of the cancer survivorship community. Just as a reminder that if you need to ask panels or we would like you to ask questions during the course of the panel today, at the right side of the screen is the chat feature where you can go ahead and key in questions. Everyone will be on the mute throughout the course of the presentation today, but an excellent opportunity to ask real-time questions using the chat feature. Just a quick note, follow us along at Twitter at hashtag CRC, and the slide is cutting off for me right there, but we'll go ahead and send that, make sure that that's actually in the chat feature so you can all follow along with that. A special thanks to Michael Sola, who is our Executive Vice President, who actually helps oversee a lot of the programming and his leadership in pulling this together, as well as our patient education team, Kevin Maccabee, and Sharon Worrell, who's new as well. And so Kevin will be facilitating the question and answer discussion at the end of today's presentation. Just a quick note, a reminder that if you have emergency medical situations, 911 is the number to call, and that with the information shared today, it's spent in general education and promotional purposes, but in no way replaces the direct advice from your healthcare team, medical advisor. But of course, we use trusted experts to provide information about relevant health topics, and we're very excited to have Heather with us today. Next slide. As I mentioned at the outset, the 1 million strong collection will be coming to Nashville. So here's our really fun and exciting feature slide, thinking a little bit about what we're trying to achieve in April in Nashville. April 1st will be the showcase and the panel, which Heather will be a part of, really featuring a lot of the action-oriented items that people can do, looking at the 50 and under phenomenon in terms of thinking about how do we tackle family history, signs and symptoms, and management, and understanding a little further about the data relevant to understanding the under 50 diagnosis and what we're seeing in terms of the data and science that are specific to people who are diagnosed with colorectal cancer under age 50. One special feature, though, of course, about the 1 million strong collection this year is that we're really trying to look at the change makers, people who are doing innovative strategies and really drawing on strength, hope, and inspiration through a lot of different means. At our Fight CRC website, you can join in to share a little more about maybe some of the particular efforts that you might be involved in. We'd really like to showcase a lot of the efforts that are happening, not just in Nashville, but throughout the country, that really draw upon the strength and inspiration from all colorectal cancer survivors throughout the US. Next slide. So today we're very, very excited to have Heather Herrmann, who is a genetic counselor in Nashville, Tennessee, who's actually one of our partner organization, and again, has been a pivotal partner in bringing 1 million strong to Nashville. She has, of course, an extensive pedigree in terms of her scientific training, as well as her genetic counseling degrees and definitely been a trusted expert where she's focusing on the area of hereditary cancer syndromes and cancer risk assessment, and works with the Thomas Healthcare genetic team, where she really looks at a lot of risk assessment with personal and family history. So we're very excited to have Heather. I should also just note that Myriad Genetics is one of the partner organizations, and I know Heather works very closely with the Myriad team with a lot of their reach and a lot of the services that they provide to the medical community and survivor community. So we're really excited to have Heather join us today, and I think we are ready to turn it over. Just a quick reminder though, of course, chat feature, please type in any questions that you have, and Kevin will be facilitating the discussion after our presenter Heather. So just give a quick mention and note, or just a quick transition of slides here, and we will begin.
Thank you. I'm really glad to be with you today and to talk about Lynch syndrome and colorectal cancer genetics. I have no disclosures to share, except that I work at St. Thomas Health as a genetic counselor in support of these fine-looking young men. So I look forward to discussing Lynch syndrome and colorectal cancer genetics today. So as we know, as we begin to think about Lynch syndrome, colorectal cancer genetics, it's important to understand how to clarify and how to think about our personalized risk for cancer. So today, I hope to define cancer risk assessment and think about what is the risk of cancer. Is it average risk, increased risk, high risk? And describe medical management modifications based on those risks. How does risk assessment impact the care of an individual? And then we'll also want to outline the process of genetic testing for hereditary colorectal cancer conditions, because of course, as we think about risk assessment and stratification of our risks, it's important to really think about how to clarify that risk and be able to better personalize the management based on that genetic testing. I apologize here. I've lost a slide control. There we go. So, as you all know, colon cancer is the second leading cause of cancer death for men and women combined, and it impacts 137,000 men and women per year. When it's caught early, the 5-year survival rate for early stage colorectal cancer is greater than 90%. But 4 out of 10 cancers are found at that early stage. So, you know, there's an opportunity to really increase the number of cancers that are found at an early stage. In general, we want to think about polyps as the precursors for colorectal cancer, and we know that colon polyps develop from the lining of the polyp and grow until they become a colon cancer. And it usually takes about 10 to 15 years for those colon polyps to develop into cancer. And so while that may look different for someone who is at that highest risk, we want to think about how we can optimize the screening in order to reduce the risks of cancer. So we know that only half of the people that are due for colon screening actually pursue that screening. And I found this, what I thought was a cute cartoon at the Daily Medical Examiner, and it was entitled, "Even Polyps Have Dreams." And as you look at it, you find 2 colon polyps. One is the instrument, the snare is approaching, and one of the polyps says, "Don't snare me, I swear I'm benign or harmless." And the other one says, "I'm a young polyp, I've got my whole neoplastic transformation ahead of me." And that neoplastic transformation is the technical terminology for the development into cancer. So while we know no one likes colonoscopies, as it says at the bottom, we know that they're important in really impacting that risk of colon cancer. So in order to think about who is at risk for colon cancer, you know, we want to recognize that we all are at risk for colorectal cancer. Every single person will fall somewhere in this pie chart. And it's really the key to understanding the risk is to understanding whether you fall into the green or the average sporadic risk, into the yellow portion of the pie chart where there's increased risk, perhaps called familial risk, or perhaps you are someone who falls into that high or hereditary risk of colorectal cancer. And the difference in risk for individuals who fall into the pie chart is significant. One way to think about this is to think, how do we define and think and identify who is at which risk level? And for individuals at the average risk, these may be folks who have no first-degree relative with colon cancer. They may have no otherwise strong family history of cancer, and they may not have a personal history of colon polyps, cancer, or any other significant risk factors. These are the folks who develop that sporadic colorectal cancer. And then we find folks who are at increased risk. These individuals may have had a first-degree relative with colon cancer. They may have a strong family history beyond the first-degree relatives. Or they may have had a personal history of colon cancer, colon polyps, or other significant risk factors, which we'll talk about in a moment. And then, of course, we know that the smallest group was this high-risk group who may be diagnosed with a genetic mutation that places them at extraordinary high risk for colon cancer, or they may be undiagnosed but still have that genetic mutation. Additionally, we think about folks who have a first-degree relative who know that they have a gene mutation, but the individual themselves have not been tested. And so by default, we know that they are at high risk for having that same genetic mutation. So when we think about the risk for individuals in the different risk categories, we know that that largest portion of the pie, the folks in that average risk or sporadic risk, face up to about a 5% risk of developing colorectal cancer in their lifetime. Where folks in the familial risk, where they have an increased risk based on some of those factors that we mentioned before, are up to a 20% lifetime risk of colorectal cancer. And then we have the folks in the hereditary cancer risk. And those folks could face up to 100% risk depending upon the gene. And so this next slide sort of breaks that out a little bit for us. These are not, these are up to risks. These are not absolute risks for colon cancer based on different genetic mutations. And so they give an idea of the real difference that people face based on the specific genes that may be increasing their risk for colorectal cancer. And so you can see risks that go from very high to more moderate risks. And we'll be talking in a little bit about how risk management, or the management of those risks, is really outlined based on the varying degrees of lifetime risk of colorectal cancer. And one of the things that's important to know is that some of these genes actually also increase the risk of other cancers, other related cancers. And so while we think about sometimes colon cancer is really the forefront cancer that makes us recognize that the person is at risk for these other cancers, oftentimes other cancers may be the key to helping us uncover the colorectal cancer risk. And so on this slide you see the genes, and if you look within the hashtags you find the different types of cancer that can be associated with a specific mutation. And even among individuals with mutations, perhaps, for example, with Lynch syndrome, you see slightly varying degrees of risk for other cancers. And so really defining exactly which gene mutation an individual has will be important in clarifying exactly which cancer risks are they face and which cancer risks can be reduced. So does risk assessment really make a difference? And we know that it does. As I mentioned earlier, the 5-year survival rate for early stage colorectal cancer is greater than 90%. We know that over 60% of the deaths from colon cancer could be avoided by screening. And we have data that shows that individuals who know their risk are more likely to seek surveillance. One study by Halbert et al. In 2004 found that 73% of patients who were known to have Lynch syndrome pursued colonoscopy within 12 months after testing. And this was distinctly different from the individuals who were untested. So how do we go about colorectal cancer risk assessment? We know that risk assessment allows for personalized management of individuals and their risk for colon cancer. And we know that management can be directed through a healthcare provider looking at the guidelines for management in order to consider multiple options for reducing that risk. It could include increased screening and watching closely with monitoring, such as a colonoscopy would be an example. Medications could be indicated. For example, aspirin might be something that would be considered for reducing colon cancer risks. Birth control pills might be something that would be considered for reducing ovarian cancer risk in individuals with Lynch syndrome. And then we know that surgeries may be indicated to remove a specific organ before the individual develops a cancer. And so there are multiple components of risk assessment that need to be considered. Of course, a person's own history, personal history of cancer should be evaluated. Whether or not tumor testing has been shown to indicate an increased risk, and we'll talk about that in a moment more. A personal history of polyps is something to be recognized, as well as inflammatory bowel disease or other risk factors. And then beyond that personal history, we want to think about familial history or family history. Who in the family has had cancer and what type of cancer they might have had. What is the ancestry? Is there other medical or social history that needs to be recognized and included at increasing the risks? And then, of course, the genetic test results that are available for the individual or from individuals within the family will be important in that risk assessment. And right now we think about two different types of genetic test results that you might consider somatic, which would be those genetic results that come from the specific tumor, or germline testing, which is the testing that comes from the DNA that's inherited within the family. So let's talk a moment about these personal risk factors and these personal red flags or warning signs. Colon cancer before age 50 is something that should raise a red flag and make someone take notice. If an individual has 2 or more Lynch syndrome cancers, including colorectal cancer, diagnosed at any age, that should raise a red flag or warning. Abnormal tumor testing by either microsatellite instability or IHC, immunohistochemistry, and specific colorectal tumor features before age 60. are also factors that would raise a red flag. Additionally, someone who has had endometrial cancer before 50 is someone who needs to be thinking about their risks for colon cancer. And there have been several different risk calculation models that have been developed. They go by the name of MMR Pro, Prim 126, or MMR Predict. And these are actually spelled out in the guidelines, recognizing that individuals that have a score on any of these that is at or greater than 5% risk for Lynch syndrome should be somebody who needs to be further evaluated for Lynch syndrome. Additionally, we want to think about individuals who have a personal history of more than 10 colon polyps or 10 colon polyps or more, inflammatory bowel disorders, or features beyond the colon, including desmoid tumors, papillary thyroid cancer, hepatoblastoma, or other conditions. And so I've mentioned a couple of times this tumor testing, and so for those who are not as familiar, I thought it'd be important to take a moment to outline that there are several different types of tumor testing. One is called microsatellite instability. One is called immunohistochemistry. And these can be, these are tests that can be done on tumor tissue. They can be done individually or can be done in combination. These are screening tests to look for the the result of the abnormal gene function, and they are automatically ordered on all or some colon cancers at some hospitals. So this is something that has been put in place as a protocol for some institutions. If the results of the testing is abnormal, further testing may be indicated to identify hereditary cancer. And so to the right, the image that you see is an image of immunohistochemistry testing. You'll see the tumor slides on the left-hand column are all normal. The staining that has been done for each is listed down the left-hand side, where you see MLH1 staining for the protein, the MLH1 protein. And if that is normal, that stain will pick up and it will show there. If it is abnormal, the stain will not pick up and it will not show, indicating that there is perhaps a problem with the protein of MLH1. You look down the line and you see different proteins, MSH2, MSH6, and PMS2 genes that are being evaluated, and the normal tissue is picking up that stain. On the right-hand side, the abnormal tissue is not picking up that stain. Again, this is a great screening test to help identify individuals who may have Lynch syndrome. Greater than 90% of Lynch syndrome tumors will be either microsatellite unstable or have an MSI high result, or have a lack of expression in the immunohistochemistry profile. But it's also important to know that 10 to 15% of sporadic colon cancers may have abnormal IHC and are MSI high. And so BRAF testing is a gene that can be looked at to see if there's a change or a mutation that might confirm that that is in fact a sporadic colon cancer. If the BRAF gene is mutated, then the Lynch syndrome genes may not be working because of an acquired problem and not because of an inherited gene mutation. However, if the individual meets other personal red flags, genetic testing may still be warranted. So if these tests were normal, but the individual had a colorectal cancer before age 50, it may still be important to pursue genetic testing. That's just one example. Okay, and so as a reminder, these tests are not perfect. They're screening tests, but they can be helpful indications for individuals who may have hereditary colon cancer. So now we want to think about the individual who hasn't yet had a colorectal cancer or hasn't met one of those personal concerns, but perhaps has a family history. And these individuals may have someone in the family who has had a cancer and is known to have a genetic mutation. They may have a first or second degree relative who meets any of the previous personal red flags, such as colorectal cancer before 50 or 2 or more Lynch syndrome cancers at any age. They may also have 2 or more first or second degree relatives, as I mentioned, with Lynch syndrome at any age, or 3 relatives who were diagnosed with colon cancer or Lynch syndrome associated cancers at any age. So I've talked a lot about first, second, third degree relatives, and some folks say, who does that include? How far should I look? What am I thinking about? And so it's important to review the degree of relation. Our first degree relatives are our mother, father, brothers, sisters, and children. Our second degree relatives include grandparents, aunts and uncles, grandchildren, nieces and nephews. And third degree relatives include great grandparents, great aunts and uncles, great grandchildren, great nieces and great nephews, and cousins. And sometimes folks are surprised to learn that they would want to be assessing and including the cancer history for relatives as far out as third degree or further. So when we think about genetic testing, we know that we are looking to identify whether or not there is a change in the DNA that predisposed or led to the development of the cancers or increases the risk for cancer in someone who hasn't yet had a cancer diagnosis. And so if you look at the upper right-hand corner, we see the double helix DNA with the nucleotide building blocks in combination. And we think about genetic testing, as I mentioned before, in 2 different fashions. One is the germline testing, and these are the mutations that are inherited from a parent. We can find mutations by looking at a single site. We can find germline gene mutations by looking throughout a single gene or throughout several genes or through panel testing. But I think it's important in this setting to distinguish germline testing and those gene mutations that are inherited from perhaps from a parent from the somatic gene mutations that are acquired and found through tumor tests. As you look at the image on the right-hand side, you'll see that number 1 sort of indicates the DNA that is found in a cell initially, the germline, the basic DNA. And as our bodies grow and develop and our cells divide, we know that sometimes mistakes can occur within that DNA. And so as you see, the purple cell is dividing, and then it changes to a blue cell at number 3. And as that blue cell has an acquired gene mutation, that gene mutation may then divide again, and it may in fact accumulate more genetic changes, as you see in number 4, where the cell turns to that yellow color. And so somatic testing actually looks at the cells that are in the tumor where we know that many mistakes have been accumulated, and in fact may or may not give us the clues to the germline gene mutation. And so when we think about germline testing, we know that we can look for these changes in our DNA through either single site testing, where we know exactly where to look. It's important in single site testing to have a copy of a relative's result in order to know exactly which address on which gene to look. And you see in the single site image there, the arrow is pointing exactly to the location where the testing can be done. If we don't have that information yet, we may need to look all along the gene. And so you see in the image on the right, a long area of DNA that needs to be screened in order to see if the gene mutation is located there. But sometimes, so this slide talks about the germline to genetic testing options, and single site testing, as I mentioned, is the way that we evaluate specific genes at a specific location. And we must know that gene mutation from someone in the family. Or we can look at the single or multi-genes. And the way that we do that is through identification of clinical features that may help us to know where to look. Over time, within the last few years, we've been able to look at many of these genes all at once, and through one single test can evaluate many genes to see whether or not the DNA holds a genetic mutation. And so as you look at this next slide, you see a single cell with the 46 chromosomes, and you see different genes in different locations. And so as we know, looking at all of those genes in the past required us to know where we were going to look. Now with hereditary cancer panel tests, we are able to take an indication for testing and look beyond just the few genes that we may be initially suspicious of. So this next slide shows a grid of the genes down the left-hand side, and all of these genes that I share here are indicated or contribute to an increased risk of colon cancer. But as you look across the grid, you see that for some of these genes, they also have an increased risk of other cancers. And as you can appreciate, by testing for more than one gene or even more than one condition, we are able to better define the cancer risks, not only for colon cancer, but for other cancers that individuals face. So through genetic testing, we are able to look at the different genes and determine if there is in fact a gene mutation present. If so, a result will come back showing that it is positive, there is something clinically significant present that increases the cancer risks for that individual. The result could come back and show that there was nothing identified as different or unexpected within the DNA that was evaluated. And this result may say no known mutation identified. It was negative. And that may have ruled out the hereditary cancer if we are testing for a single gene mutation known in the family. But it may actually still leave us with known cancer risk. And we are left to look at that individual's personal and family history of cancer, personal and family history of polyps, personal and family history of other factors in order to base that increased medical management. And then with either of these results, we could find a variant of unknown or uncertain significance. The variant of unknown or uncertain significance, sometimes called a VUS, is a change in any sequence variation that's different from the normal sequence. It's a variant that may or may not be causing the cancer in the person or the family. And additional information is really going to be required in order for the laboratory to determine whether or not the change is clinically significant. Some laboratories are constantly, always assessing that information on a regular daily basis. And even so, that VUS may not be clarified and for many days, months, or years, but eventually we will learn whether or not hopefully the change is an innocent gene change that is just a normal variation within the DNA, or perhaps it is found to be cancer causing. Until that clarification and determination is made, no clinical action should be taken on the basis of a VUS, and personal and family history really is what's left to drive that medical management. And so as we think about genetic testing and we think about the impact of that genetic testing, this is a reminder that for many of the genes that we're discussing, the autosomal dominant inheritance is the way that folks will pass along these genetic mutations. And so in this example, you see the father who has a purple copy in one of his 2 copies of the DNA. And if we recognize that the purple copy is the copy that's changed, it's the copy that's causing the protein not to do its job. With each baby that he has, there is a 50% chance that he passes on the purple copy and a 50% chance that he passes on the orange copy. And so in this example, the mother who has 2 copies of her gene that are, in this example, orange, she will pass on 1 copy of her orange gene or unchanged DNA to each of her children. And so in the second generation, you see the 50-50 chance that the babies have inherited the purple copy, and if they have inherited that copy, then they face those increased cancer risks. What I always like to also point out in this illustration is if the person did not inherit that purple copy, then they cannot pass on the changed DNA or that genetic mutation. So who orders genetic testing and how is it done? Well, a knowledgeable provider is first and foremost the person who needs to be involved in that genetic testing. That could be an MD, a genetic counselor, an NP, a PA, nurse practitioner, or physician assistant, lots of initials and acronyms there, but really a knowledgeable provider is the person who should be ordering that genetic testing. And so a lot of times that person that the patient is seeing may refer them on to a genetic counselor or an advanced practice nurse who has specialized in genetics. And those genetic counselors are often certified and licensed in some states and really oftentimes focus on the genetics to be able to know and meet with patients about this genetic testing. There are telephone genetic counseling services that are available. So no matter where a patient is, they should be able to find some genetic services. And in order to find a genetic counselor, it's as easy as going to your internet to nsgc.org There's an image that I've shared below that's Find a Genetic Counselor. You can click on that and share your location and find the closest individual to you. And so what is the process for genetic counseling? Well, if we think about the process, the first step is to gather your history, and that can be done today. There is a terrific tool available, again, online, the Surgeon General's My Family Health Portrait, and it allows you to really think about the questions that you'll want to gather. So you can go to that website and include the information. You can print it off and take it to your provider. It'll ask questions about who in the family's had cancers and all sorts of other things. You want to include your maternal and paternal history as you're gathering your family. So both sides of the family are important. You want to think about the types of cancer, the colon polyps, the age of diagnosis that individuals were recognized to have their cancer. You want to think about your relative's current age or perhaps their age of death. And then you want to take that information and you want to share your history. Talk to your doctor, talk to your healthcare provider. And if indicated, find a provider for risk assessment and genetic counseling. Through that process, you will be able to provide a blood sample or saliva sample that will be sent to the laboratory for testing. And then those results from that genetic testing will be returned to that provider, who can then review the results and help define that medical management for you. So as we think about genetic counseling and that specific process of consultation, some of the things that you may find during that discussion, evaluation, and consultation will include a review of the personal and medical history, a review of the family history, risk assessment, so perhaps including some of those risk models that I mentioned before to determine what is the likelihood of finding a genetic mutation, discussion of genetics and hereditary risk. Certainly informed consent for genetic testing would be included as coordination of testing is occurring. And once that result of the genetic testing is returned, the result interpretation, resource identification, and additional family testing and coordination can occur. So when we think about genetic testing, we know that there are many labs and many tests. You know, in the world of technology and the world of genetics, things are popping up all the time. So how do providers decide what to order? Well, first and foremost, it requires the clinical assessment of the history and the likelihood of inherited genes. So taking into account that personal information and the personal risk factors along with that family history that you're able to share will all be incorporated to determine whether that history meets the concern and guidelines for further assessment. And so once the guidelines and the clinical picture are evaluated, the decision is made to send that testing off. Requires really a clear and astute judgment of the laboratory and the laboratory quality. So has the laboratory been offering genetic testing for a long time? Do they have strong analytical standards regarding sensitivity and specificity? So if there's a problem along the DNA, are they able to find it? If there is something found, can they help to understand, can they clarify whether that is cancer causing? Do they have test validation? Are they able to provide the robust documentation to help share what they have done to ensure that that testing is valid? And what does their variant classification entail? Reporting standards are also important. There are standards that have been developed and Are they following those standards? And then, do they have genetic counseling and genetic counselor support? I found this great quote from a past president of the American Society of Clinical Oncology, who stated, ASCO believes that the tests used to detect those abnormalities must be of the highest quality and thoroughly validated before being offered to doctors and patients. And that was President Peter Paul Yu. He said, our patients depend on high quality tests as much as they depend on carefully studied, safe, and effective drugs to achieve the best possible outcomes. And so for genetic testing that is ordered, those are the qualities and things that providers should be looking for. So once that result comes back, how do you utilize your laboratory result for improved health? Well, if the result is showing a positive, if it's positive for a genetic mutation, then it indicates that there are related cancer risks that may be present. And management will be based again on societal guidelines for directing management of that high cancer risk. If an individual is positive, then family members may need to be tested for that same genetic mutation. And if they are positive, those associated cancer risks are present. If they are negative, then those cancer risks may be back to the average risk or sporadic risk, but that assessment will be required to ensure that there is not remaining history that is outside of the genetic mutation. And then if the individual is negative, medical management will be based on personal and family history, which we'll discuss. And if there is a variant of uncertain significance, that's treated like no new information until we understand what that variant means for that risk. So management is based on personal and family history. And for individuals who are positive, reproductive options and considerations may be warranted. For the most part, genetic testing is indicated for adult onset conditions at the age of adult consent. Assisted reproduction and pre-implantation genetic diagnosis, or PGD, are potentially possible for individuals who are found to have genetic mutations. And then other considerations for individuals of reproductive age include the fact that some conditions require two mutations, biallelic, two mutations, one inherited from mom and one inherited from dad, in order to have the condition. And one of those is known as constitutional mismatch repair deficiency. So for individuals who have Lynch Syndrome gene mutation, should the partner also carry a mutation in that gene, the child may in fact inherit two copies and have this condition. So as we talked about, stratification of risk is really critical. And the National Comprehensive Cancer Network, the NCCN, has outlined guidelines for individuals who are at that high risk or hereditary risk for medical management. And so should a genetic mutation be identified, it's important for healthcare providers to look to those guidelines to help personalize that medical management for the patient. But I think it's important to review the differences and distinctions of what might be possible for individuals who have been identified with Lynch syndrome or other high-risk hereditary risk. So for individuals who are identified with an MLH1, MSH2, MSH6, EpCAM, or PMS2 mutation, Colonoscopy is indicated every 1 to 2 years. And as you all may recognize, that is vastly different from some of the general or increased risk guidelines, which might state every 5 to 10 years. And then for individuals who have MLH1, MSH2, or EpCAM mutations, colonoscopy is recognized to begin at 20 to 25, or 25 to 30 for those with MSH6 or PMS2 mutations. And this should actually be customized to 2 to 5 years younger than the earliest person in the family with colon cancer for any of those inherited mutations. But this is not to begin average screening colonoscopy. And as the guidelines point out, aspirin may decrease the risk, but it's not currently a recommendation for standard use. Additional management of cancer risks would include hysterectomy and removal of the ovaries after childbearing is complete to reduce the risk of endometrial and ovarian cancer. The guidelines state that evaluation of abnormal uterine bleeding prior to that surgical intervention, as well as screening by endometrial biopsy, transvaginal ultrasound, and CA-125 may be possible, though may and then we have gastric small bowel cancer. Endoscopic ultrasounds considered every 3 to 5 years from age 30 to 35. And renal or transitional cell cancers with urinalysis from 25 to 30 years old. An annual physical or neurologic exam should begin between 25 and 30. And of note, while we know there's some question about the input or the impact of breast cancer risk for individuals with Lynch syndrome, it's interesting that the NCCN guidelines do indicate that breast cancer risk and state average risk breast cancer screening is indicated. So we don't want to neglect that. For individuals who are positive for an APC mutation, proctocolectomy or colectomy with surveillance based on treatment. And if the colectomy with IRA was the treatment, the rectal endoscopy every 6 to 12 months, depending on polyps. If the TPC with the ileopouch anal anastomosis or ileostomy, the endoscopic evaluation should occur every 1 to 3 years based on polyps and up to every 6 months based on findings. This is vastly different than someone at increased risk or even sporadic risk, as you'll recognize. Additional cancer risks are outlined to include upper endoscopy from age 20 to 25 or earlier if colectomies before the age 20, thyroid exam from the late teenage years, or consider annual thyroid ultrasound. Annual physical and neurologic exam and abdominal palpation are also included. And for individuals who have a family history of desmoids, abdominal MRI, CT every 1 to 3 years after colectomy, and then every 5 to 10 years with abdominal symptoms prompting immediate abdominal imaging. Small bowel CT or MRI for desmoids should be considered, and screening for hepatoblastoma may be considered as well. And then for individuals who have APC mutations but may have a small burden of polyps, colonoscopy and polypectomy may be every 1 to 2 years with surgical intervention as warranted. Again, the distinction for individuals with high risk or hereditary risk medical management is uniquely different than individuals with average risk or that increased risk. And so for individuals with 2 YH mutations, one inherited from mom, one inherited from dad, colonoscopy should begin at age 25 to 30 and every 2 to 3 years if negative. If there is a small burden of polyps, colonoscopy may be warranted every 1 to 2 years. with surgical intervention as warranted. And then upper endoscopy and side viewing duodenoscopy from 30 to 35. Now, we've been talking a lot about those starting screening in the 20s. For individuals with STK11 mutations or Peutz-Jeghers syndrome, we want to think about colonoscopy beginning from the late teens and occurring every 2 to 3 years, with additional risk management, including breast imaging through mammogram and MRI from age 25, upper endoscopy every 2 to 3 years from late teens, small bowel CT or MRI at age 8 to 10 with follow-up based on findings until 18, and then pancreatic screening, pelvic exam and pap smear, and annual testicular exam and observation from age 10 for individuals. This again is vastly different than the individual's personalized screening for individuals with perhaps Lynch syndrome or MAP, as we've just discussed. And then for individuals with SMAD4 or bumper 1A mutations and juvenile polyposis syndrome, those individuals also need to think about colonoscopy from age 15 every 2 to 3 years if polyps are not found, and upper endoscopy as well. And individuals with SMAD4 mutations should be screened for HHT within the first 6 years or 6 months of life. Excuse me. So these are vastly different high-risk screenings than for individuals who have that increased or familial risk management. NCCN does point to that personalized management for those high familial increased risk folks. And they state that for individuals who have a single first-degree relative with colorectal cancer before age 60, or 2 first-degree relatives with colorectal cancer at any age, screening should begin at age 40 or 10 years before the earliest diagnosis of colorectal cancer. And then for individuals who have a first-degree relative with colorectal cancer at 60 or older, or 1 second-degree relative with colorectal cancer before 50, screening should begin at age 50. And certainly individuals who at age 50 or at the age of onset of adenomas in relatives, that should be included in the consideration of screening for advanced adenomas. So as we think about that highest risk group, and we think about the individuals who perhaps have fallen the familial risk group, I think it's important to recognize that we all have a risk for hereditary cancer, or we all have a risk for colorectal cancer. And it's important to stratify and to understand our risks so that we can help reduce the risk of developing those cancers. So on this slide, I share some of the ways that we can choose daily to assist in risk reduction. They include don't smoke, or if you smoke, stop smoking, increase your physical activity, maintain a healthy body weight, and avoid overall body fat, especially that fat around your waist, and reduce how much red meat and processed meats you eat, and use alcohol in moderation. And so as we think of these things, it's important for all of us to consider these risk-reducing opportunities, but for those of us at high or increased risk, this is not enough. And so my hope is that the information today will help to inform and empower you to take action and to learn about specific risks and individualized risk management. So in summary, learn your cancer risk learn your risk for colorectal cancer and other potential cancers, and manage that risk effectively. Thank you.
Thank you so much, Heather. We really appreciate you taking the time to go through all this information with us, and we've had a lot of questions come in, so Given our time, I'm going to go through and ask as many as we can, and if we don't address something specifically, we will be doing some follow-up discussion and blogs about the topic. And then also, as a reminder, we'll be in Nashville, where we will talk about colorectal cancer in the under 50, and Heather will be one of our panelists there. So we'll hopefully be able to address some other concerns there as well. So what I'm going to go ahead and do is go through a couple of the questions. And let me go ahead and share one of our question slide here. Give me just a second. So what we are hoping to do with colorectal cancer in the under 50 and talking about genetics, Heather, we've had a lot of questions come in about insurance coverage of genetic testing, and then also what type of provider should you have if you have a Lynch diagnosis and have experienced several different types of cancer. So if you could address those two questions first off, that would be great.
You bet. Absolutely. So as far as insurance coverage, for individuals who meet those risk factors for hereditary cancer, insurance coverage is excellent. It is well outlined and well described for patients who do have those red flags, those warning signs, they meet the NCCN criteria, that it is to the advantage to identify patients in order to keep them as healthy as possible. So, I think most patients have no problem at all if they are clinically indicated in getting that coverage. And then the question about who and what providers, I think oftentimes of individuals who face multiple cancer risks or cancer risks for multiple types of cancer, as having a real collaborative team approach to their care, and finding multiple providers who specialize in the types of cancer that they are at risk for. For example, working perhaps with your point of care provider to ensure that you are working with the colorectal specialists and the ovarian cancer specialists. These are going to be the endometrial cancer specialists. These are going to be the folks that you want to have on your medical team to help guide that management and help determine when screening is perhaps warranted, and perhaps even more surgical intervention is in order.
Thank you. So looking at testing that comes back VUS, what percent of that is typical, or what do you see working with patients? What percentage of testing is it that comes back VUS?
Gosh, that's a great question. The VUS percentage, it's actually really low if you're looking at a very single gene. But as we've started looking at more and more genes, we've seen, it's sort of the more genes you look at, the higher that VUS percentage is. And so it really depends on exactly how narrow or how broad you're looking. And so, it's a little bit of a hard percentage question to answer. But I think, one of the things with the VUS is that we recognize it's possible anytime we are looking across a gene that we will encounter something that hasn't been seen before. Even for genes that have been studied and tested for a long, long time, we know that that is a possibility. And the laboratories do a great job at really clarifying that risk as quickly as possible and working very hard and diligently to help individuals understand what variant means for their medical management.
So could you please repeat, this question came in, if you could please repeat what you said about PRE testing, genetic counseling? It may be pre-testing or PRE testing, I'm not sure.
PGD, probably.
That's probably it, yes.
Yeah. So the pre-implantation genetic diagnosis is sort of the technology, it is the technology that is available for individuals prior to implantation for, prenatal testing and prenatal evaluation. So for those individuals who are seeking a pregnancy and know their genetic information and perhaps want to have that genetic information selected or managed, for example, if individuals are at risk perhaps for two, a mother and a father both carry a gene mutation, you could definitely seek a prenatal evaluation and see about testing prior to implantation of that embryo. Even for individuals who just carry a single mutation, that is something that is technologically available. I don't know if that was the question.
I think so, yes, thank you. So this is a specific question about a variant of Lynch. So how frequent, and I'm not sure if I'm saying this correctly, is the Muir-Torre variant of Lynch, the MSH2?
Oh goodness, percentages. I don't know if I have that off the top of my head for the current percentage of Muir-Torre. Certainly we look at clinical features of the different mutations in order to help classify syndromes. A syndrome is a collection of features, and so as you think about all of these conditions may have first been recognized by the collection of features that they displayed. And so Muir-Torre would be one example of a collection of features. The percentage of individuals within that gene that have Muir-Torre, I don't have that number off the top of my head, but I can try to look it up and share that with you.
Thank you. So we've talked a lot, and you did a wonderful job of talking about first, second, and third degree relatives. So is there anything else that we should know or discuss about second line relatives? I know that you shared some of the guidelines about second line relatives when considering genetics. I know we often talk about first line. So how important or influential are second line relatives when considering genetics?
Incredibly important. When we start to think about our risk factors, we know that there are a lot of things that can mask or keep us from recognizing the full impact of that risk. And so the greater information you can gather from the relatives that you can get that from, the better risk assessment can be provided. And so if you think about first degree relatives only, that's a pretty limited group for most folks, where we think about mothers, fathers, and siblings and children. So when we're looking for hereditary pattern, that second degree relative, whether it's the grandparents, aunts and uncles, and others, is really often critical. It's critical for that risk assessment, and it's often critical for defining who is then going to get that coverage. So for the genetic testing. So I think it's important to really make sure folks, sometimes we don't have access to that information. We don't have the ability to know that. But when possible, gathering the information. I know a lot of times we don't even talk about colon polyps. We don't share that information. But the more that we can get from our relatives about the cancer diagnoses they've had, have they had colonoscopies? Were there polyps found on their colonoscopies? How many polyps did they have? How often did they have to get colonoscopies? And did they find polyps every time they had colonoscopies? These are the kind of thing that that can't be stressed enough, is really critical in helping to define that risk and risk assessment.
So I think I'd like to end with the question and get any of your last thoughts on this. So first, thinking practically, if someone is listening and thinking about if they have a very strong family history, if they've had a lot of cancer in their family, or if they've even been told by a healthcare provider they didn't need to get tested for Lynch syndrome or another genetic syndrome, but they are thinking that they do have a very strong family history. What practically should someone do with that information of family history? What's the next step?
Share it, tell it, find someone who will listen. If you have risk factors that met the red flags that I mentioned, don't take no. Don't let someone tell you that the chance is low. Seek a second opinion. And that second opinion could be from another provider, it could be from a genetic counselor. But you know, if you find that you meet those red flags, if you find that you have a concerning history, you know, my hope is that this presentation was able to share and show that there are things that can be done if the risk is accurately and adequately defined. And so in order to do that, individuals, the doctors, the healthcare providers, the folks that are helping patients know how to manage their risk need to know what that risk entails. So share it, and that would be my advice.
Thank you so much, Heather. This has been very helpful, and we look forward to having you on our panel in Nashville. I want to thank Myriad for the webinar sponsorship, and also I do want to briefly mention, and I put this in the chat feature, but if anyone does have a Lynch diagnosis, I would suggest they take a look at the Heroic registry. The link is in the chat feature. You can take a look at that. It connects patients with researchers, and so it's a tool that's brand new. But we are hoping to spread the word about that as well. So thank you so much again, Heather. We really appreciate it. Thanks everyone for tuning in.